I'm Dr. Melissa Black of Empower Family Medicine, and in this video series, we'll be talking about medical documentation. The goal of the series is to help my first-year medical students who are writing progress notes for the first time and charting for the first time, and also to help patients understand their own medical documentation so they know where to find things and where to look for errors so they can be an active member of their healthcare team. When I first meet a patient, the first thing I do is interview them and do an exam, and I document that in what's called a history and physical. It's a very complete form of medical charting that includes all of their past medical history so that we have a good big picture of what's going on with that person. So, for my students, let's talk through the individual components of a history and physical. We start with the chief complaint, which is why a person comes in. Sometimes it's just to establish primary care, or maybe they have a specific complaint like a headache. Second part of your note is the history of the present illness. So we talk about in history of present illness, as I learned it, OPQRST. So O is for onset, when did the problem begin? P is for pain, if there's pain involved. Q, what is the quality of the pain? Is it a dull, aching, or sharp stabbing type pain? R is for radiation. Does the pain travel anywhere? Does it radiate down the leg or into the neck or down the left arm? S is for severity. Would you describe it as mild, moderate, or severe? And T is for timing or triggers. What is the timing of the pain? Is it continuous all day, or are there certain things that trigger it, like cold weather or prolonged standing? So that's how we take a history of present illness for a pain complaint. The same sorts of descriptors can be applied to all sorts of medical concerns. So OPQRST. Next, after the history of present illness, is the review of systems. The review of systems is asking a person about any related symptoms from head to toe throughout their body system. So generally we think of weight loss, appetite, sleep. Next we might ask about head, ears, eyes, nose, and throat symptoms. If you're having any runny nose, any drainage from your eyes, any change in vision, any headache. Next, we might ask about respiratory complaints. Are you having any shortness of breath or wheezing? Cardiac, are you having any palpitations, skipping in your heartbeat, chest pain? GI, are you having any stomach upset or changes in your usual bowel habits? GU, do you have any bladder symptoms? Do you have any flank pain over your kidneys? Is there any change in the color of your urine? Genitourinary might also include reproductive or sexual health history questions. Do you have any sexually transmitted disease history or symptoms like discharge or rash in the genitourinary area? GU. Musculoskeletal. Tell me about your joints. Do you have any large or small joints that are painful or swollen or discolored? Dermatologic or skin. Do you have any skin rashes anywhere? Sometimes we'll separate out the lymph system. So do you have any lumps or bumps or swollen glands anywhere? Neurologic. Are you having any trouble with balance, coordination, swallowing, dizziness, any neurologic symptoms? Psychiatric. Are you having any symptoms of depression or anxiety? Any delusions or hallucinations or other psychiatric symptoms? You could include podiatric separately also for foot-related symptoms. So a review of symptoms is a head-to-toe list of complaints a person has. Sometimes when you're doing your initial history and physical and you're learning to do these, it gets a little bit confusing to keep separate what is a past medical history and what is a review of systems. In review of systems, I'm asking about symptoms a person is having. That's different from their past medical history, which is a list of diagnoses a person has. So after review of systems, we ask about past medical history, What are the diagnoses that you have had? A symptom might be headache. A diagnosis might be migraine. Well, I have migraine headaches and I take this medication for it. So past medical history, any illnesses that have been diagnosed. Past surgical history, have you had any surgeries or procedures? Social history can include a lot of things. What is a person's first language? Where were they born? What sort of housing did they grow up in? Was it a place where they were around pesticides or lead paint? Did they have any chemical exposures? Did they have any intentional chemical exposures like nicotine or marijuana or recreational drug use? What kind of occupation or hobbies do they have? Do they have any exposures from those activities? What sort of stressors are in their life and what do they do to help relieve stress? What sort of relationships are important to them? And are there any health issues with those? So that's social history. Also, if they drink alcohol, how much do they drink and what type? How many drinks per sitting is a person drinking? If they're smoking, we want to know how many packs per day and how many years. We call that pack years. So 2 packs a day for 10 years would be 20 pack years. Those are important elements of the social history. Next, we make a list of all their medications and any allergies. When we talk about allergies, or you're talking to your care provider about allergies, we want to distinguish between a true allergy and a side effect. So a true allergy is I took penicillin and my throat got swollen. I had difficulty breathing and I had hives from head to toe, or just diffuse skin rash. That's a true allergy. A side effect is when I take Cipro, I feel nauseous and I vomit. It's different than a true allergy. Both are usually noted under the allergy section, and that's why it's very important when you're the person taking the medical history that you know what was the drug and what was the reaction, because we really want to know, was this a true allergy or was it just a side effect? After medications and allergies, we've completed our medical history. We move on to the exam, where we document our exam findings again head to toe. And then lastly, assessment and plan. So sometimes when you see notes, you'll see the assessment as one section and the plan as a separate section. I usually chart assessment and plan together, but the concepts are still the same. So I was taught to use the mnemonic PEST, P-E-S-T, to help guide the charting of my assessment and plan. The assessment is really the P, E, and S part, and the plan is the T part. So if you're splitting them up, you can split it up that way, but I just chart P, E, S, T for each condition. So, for example, assessment and plan, the P, we start with the P, which is the problem. We list E, the etiology or cause of the problem. The status, is it controlled, uncontrolled, stable or unstable? And the treatment plan, which might be listed in your plan section separately, or you can list it all together. So let's take an example. If we're writing our assessment and plan, and we have a person, we'll say, with constipation, diabetes, and hypertension. So number 1, problem constipation, etiology, in this case, constipation secondary to pain medications. Status, uncontrolled. The patient comes in saying, I have not had a bowel movement since they gave me Percocet for my sprained ankle. So constipation, secondary to pain medications, uncontrolled. And then T, for treatment or therapy, prescribe Senna, 2 tablets once a day, call if no bowel movement in 3 days. So problem, etiology, status, and treatment plan. Let's try another one. Diabetes, type 2 diabetes is the problem. Etiology, you don't always know the cause necessarily, so you may just, you may leave it blank, or, diabetes, you might put secondary to family history or idiopathic. Sometimes you do know the cause and sometimes you don't. The status, in this case, the patient has controlled diabetes. They're taking metformin, their A1C was 6.5%, so status controlled, and treatment plan will continue metformin and check creatinine, because we know that medication affects the kidneys, so we need to check creatinine. So that's our treatment plan. try one more. Let's see, this person also has hypertension. Problem, hypertension. Etiology. We may suspect that this person has high blood pressure because they are taking a lot of caffeine, like energy drinks. These people who exercise a lot and are always drinking energy drinks with caffeine. So maybe this patient was never hypertensive before, and now we think it might be related to that. So problem, we could say new onset hypertension. Etiology, secondary to excessive caffeine intake. Status, uncontrolled. Blood pressure in the office was like 165. Treatment plan, recommend discontinuing use of caffeine products. Check blood pressure medication at home once a day with the home blood pressure cuff. Record in a log and return to clinic in 1 week to review the blood pressure log. So there you have it. That's a nice way to chart in an organized fashion your assessment and plan. PEST, PEST, problem, etiology, status, and treatment.